Subcommittee will now come to order. As clerk, do you want to open up the roll? Please signify your presence on the electronic voting board. Get it to light up? Nope. You want to call roll?
Okay. Delegate Price. Delegate Willett.
Here.
Delegate Herring. Here. Delegate Shen. Delegate Hodges.
Here.
Delegate Waxman. Here. Delegate Taylor. Chairman Hope.
Here. All right. Well, welcome to the Health Subcommittee. We have our first patrons already here. Delegate Wiley, you're first with House Bill 1552. Tell us what your bill does.
Good morning, Mr. Chairman, members of the committee. House Bill 1552 is in front of you. I do have an amendment nature substitute on there.
All right. Could ask the clerk to report in a minute.
Mr. Chair, there's a substitute it's changing it so that there's an average over the fiscal year of the hospital. Instead of saying that you can use any number of beds as swing beds, it's saying that critical access hospitals can use up to 10, but it calculates that on average over the fiscal year. If a hospital does not meet that average, they lose the privilege after 2 years, and then they have to calculate it daily until they've come back into that average after a certain period of time. I think that captures it. Yeah.
Or does everyone have the substitute? Is it online?
Should be in front of
Mr. Brooks? Okay. All right. Can I get a motion to approve the substitute?
So moved.
Second. A motion properly second. All in favor say aye. Aye. Opposed? Okay. Bills before is this substitute. Delegate Wiley.
Thank you, Mr. Chairman. Current situation is the members operating critical access hospitals, CHSs, have identified discrepancies between state and federal law regarding limits on CHH swing beds. The inconsistency presents challenges in placing patients effectively. The term swing bed doesn't refer to a specific type of physical bed, but to a particular stage of medical care. A swing bed program, more commonly known as transitional care, allows hospitals, especially those serving rural and remote areas, to use these beds for acute or post-acute care as a patient needs change. Current state limits swing beds to 10 of the 25 total beds in these critical access hospitals, whereas federal law imposes no such specific limit on the number of swing beds. So what the solution is this bill allows critical access hospitals to calculate the 10 swing bed daily limit as an average over the hospital's fiscal year. If the fiscal year average exceeds 10 swing beds, the critical access hospital has the following fiscal year to reduce the average to 10 or below. I have folks here from the association to answer any questions.
All right.
Thank you.
Thank you, Delegate Wiley. Is any member wish to seek recognition to ask a question of the patron? All right, Delegate Hodges, you're recognized.
Thank you, Mr. Chairman. And just to clarify, a swing bed, you're looking at, acute care versus post-acute care.
Correct.
And it's a level of care at that point and allows the patient to, I guess, seek the long-term treatment that they need, especially in our rural areas that may not have a bed close by, so they can stay there, recover, and be closer to home. Is that correct?
Mr. Chairman, that's the way I understand it. Correct.
Okay.
All right, thank you, Delegate Hodges, for that clarification. All right, let's hear from testimony from the public. Anyone here to speak in favor of House Bill 1552?
Good morning, Mr. Chair, members of the subcommittee. Brent Rawlings for the Virginia Hospital and Healthcare Association. Thank you, Delegate Wiley, for bringing this legislation forward. There are some critical access hospitals in his district that have bumped up against this 10-bed limit, creating the situations that Delegate Hodges just mentioned there. We did work closely with the Virginia Healthcare Association on this. They came to us with some concerns about it last year, worked with them over the offseason to come up with these guardrails here, calculating the 10 beds over average, not allowing more than 15 at any one time for 5 consecutive days, a requirement that if you do exceed that 10-bed average over the course of the year, you have to kind of pay it back over a course of 2 years to correct. And then lastly, a requirement to at least make a good faith effort to find a placement in the community. What we found is in these situations where we've got somebody that needs to move from inpatient care to nursing home care, there's not a bed available in the community in some instances. or that available bed in the nursing home is not providing the level of skilled care that's required based on the specific needs of that patient. So this allows them to stay closer to home and not have to move away from their family. And just for reference, just so everybody knows, critical access hospital, these are small rural hospitals this is a federal definition. They're required to have emergency services in the community. Federal law allows all 25 beds to be operated as swing beds. We've got this rule in the state. Not exactly sure how the 10-bed limit was arrived at, but it's been in place for quite some time. We think it was based on previous interpretation of federal law. These eight critical access hospitals in the state all of them do provide swing bed services, and this would just allow them additional flexibility to care for patients in their community. So thank you, and hope you support the measure.
Thank you very much. Anyone else here to speak in favor? How about in opposition? All right, I know no one is on the call or anything like that. So do you want a last word, Delegate Wiley? I think your bill's in good shape.
I appreciate passage of the bill, Mr. Chairman.
All right. All right, got a motion, properly second. Please vote on your electronic voting device. With amendment, excuse me. Or substitute, rather, as a substitute. It was a substitute, I believe. All members have cast their vote? Okay, the bill's reported as substitute on a vote of 6-0.
Thank you, Mr. Chairman, members of the committee.
Wiley.
Have a good day.
All right, Delegate Waxman, I see you're here, and then you'll be next, Delegate Williams. Not Waxman, I'm sorry, Runyon. Excuse me, Waxman's to my left. He was in my ear.
So I
earlier.
appreciate that. Good morning, Mr. Chair, members of the committee. We have a government efficiency bill, House Bill 1571. In 2009, Division of Vital Statistics began a journey to develop Virginia's electronic death registration system. From the start of the background work at that time until it was officially implemented in October 31st of 2014, the goal to electronically streamline gathering vital records as they pertain to deaths in Virginia. Many stakeholders engaged in this process. The program has been updated and continues to be improved based on stakeholder input. In keeping with the efficiency, there are 2 reports that are no longer necessary. These are paper reports because the information is being captured electronically and can be gathered when necessary by either the Division of Vital Statistics or the Board of Funeral Directors and Embalmers. I think it's important to note both groups are on board with this change, so I would appreciate your all's support of this bill to eliminate unnecessary paperwork in the system.
Okay.
Thank you. Happy to answer any questions.
Thank you, Delegate Runyon. Anyone member seek recognition, ask a question of the patron? All right, seeing none. Anyone here from the audience to speak in favor of House Bill 1571? Yes, welcome.
Hi, Angie Bezick with Principal Advantage Government Relations Group on behalf of the Virginia Funeral Directors Association. And we thank Delegate Runyon very much for bringing this bill forward. And as he said, we worked in collaboration with DVR and the board and the other association members to bring this forward.
Thank you.
Thank you.
Morning, Mr. Chairman. Scott Johnson on behalf of Services Corporation International. We support the bill.
Morning, Mr. Chairman. Bo Keeney on behalf of the Independent Funeral Homes of Virginia, and we support the bill.
Good. Anyone wish to speak in opposition to House Bill 1571? Any members wish to seek recognition of questions of the patron? All right. What's your pleasure? Report properly second. Any questions? All right. Please vote on your electronic voting device. Clerk will close the roll. Bill reports by a vote of 6-0.
Thank you, Mr.
Thank you,
Chair.
Mr. Runyon. All right. Delegate Williams, you're next. House Bill 1555. And for those wish to testify, and I don't know if you noticed, we're putting a 2-minute time limit for each speaker, so I just want to make sure that everyone's aware to stay within your 2 minutes when you're testifying for and opposition. Delegate Williams, House Bill 1555.
Yes, thank you, Mr. Chair, and thank you to the committee. This bill is somewhat unique. It would allow for a healthcare regulatory sandbox program. It requires the Department of Health to establish the healthcare regulatory sandbox program. It enables a person to obtain limited access to the market in the Commonwealth to temporarily test an innovative healthcare product or service on a limited basis without otherwise being licensed or authorized to act under the laws of the Commonwealth. Under the program, an applicant requests the waiver of certain laws, regulations, or other requirements for a 2-year testing period with the option to extend another 6 months. It provides the application requirements, consumer protections, procedures for exiting the program or requesting an extension, and record keeping and reporting requirements. The bill requires the department to provide an annual report to the chairs of the House Committee on Health and Human Services and the Senate Committee on Education and Health that provides information regarding each program participant and recommendations regarding the effectiveness of the program. This does have an emergency regulation to implement the provisions of this bill, and also has an expiration date of July 1st, 2030. And before I go further, there is an amendment that I'd like to move.
Okay. Mr. Brooks?
Mr. Chair, there is an amendment in the nature of a substitute. It adds 2 provisions. The first says that the participants in the regulatory sandbox shall be liable for all expenses related to their involvement in the program. And the second specifies that nothing in the chapter shall be construed to waive any of the COPN requirements. That should be it.
Okay. Can I get a motion to move the substitute? Second. Motion properly second. All in favor say aye. Aye. Okay. The bill's before us, and I think you've explained the bill as it was substitute. Is that right?
That's right.
Delegate Williams.
I'd like to point out one definition for everybody. Innovative healthcare product or service means a healthcare product or service that includes the use of or incorporate new or emerging technology or existing technology. So what our goal is to allow us to play in a sandbox that is sort of a pilot program for 2 years.
Okay. Good. I think we've seen this bill a couple years ago. Does any member wish to have a question? Delegate Waxman, you're recognized.
Thank you, Mr. Chair. Mr. Chair, I'd like to ask the patron with that definition. So the intent of this legislation is it limits the product to just a software type application, and we're not talking about medications, devices that are used in surgery. Is that correct?
Delegate Williams.
I'd like to ask one of my friends that's coming up behind me to answer that, because I think that it expands more than just software.
Mr. Chair, Delegate Waxman, the program
Can you
is
identify yourself?
Oh, yeah, sorry, Ben Knotts, Americans for Prosperity. The program is designed for innovative products that can that improve healthcare outcomes. That they can be tested and demonstrated, so that the government can see that there is evidence behind it. That there's evidence based, so that we can change reimbursement policy. So that because a lot of medical innovations are determined around reimbursement policy and whether it's adopted or not. I'll give you an example. This committee has acted, and AFP has been big champions on telemedicine. Remote patient monitoring was proven by UVA over 20 years ago to be effective in saving lives and saving money. And yet it wasn't until right before the pandemic that we actually started reimbursing that. So we want to expedite that time frame so that we can demonstrate that a program is effective. So it's not merely, if the tech is viable, the Department of Health Professions they're able to determine whether or not it's going to be a good program or not to do it. And just for scale-wise, everywhere this has been done in the country, and there's 27 sandboxes of different types in the country, there's only about 1 or 2 programs that are approved a year, and those programs are temporary. So this is not going to be a wide free-for-all. It's very targeted to improve healthcare outcomes. So whether it's a digital innovation, there's a company I know called Life. They use blockchain. When you go to the doctor, you got to fill out those forms over and over and over again. They use blockchain to expedite that, but there's a lot of red tape they would have to go through. They want to demonstrate their product. That's an example. So it's broad, but it's very specific to that outcome, and we can trust the regulators to make that determination.
Can I ask a question, Mr. Knotts? Over here, can I ask a question? About products that need to be FDA approved, or do these products have to be approved by the FDA?
So there is a space that I think exists that would qualify. Virginia has right to try laws, and the federal government has right to try laws. So there is a scenario in which you could you could hypothesize, and I'll give you an example. A 3D printed organs is something that is common, has been known for 20 to 30 years. It's cost effective. It can save lives and money. The FDA won't let any kind of pilot program go for that, but under right to try, they can do that. But the companies, again, FDA policy determines whether or not these technologies can get to the market and can determine the expedition in which it comes to market. So what we're trying to do here is give them an environment in which the government can oversee the safety of the participants and say there is evidence to say we need to change the law to save lives and money. That's the outcome of this that we're pursuing.
So you'd be superseding FDA's
No, we'd be
authority.
complying with FDA with a right to try
Under
laws.
right to try.
And that's only in a very specific circumstance when it's someone is terminal and they're saying, hey, I want to save my life. I want to try this product.
Yeah.
So
That's a very narrow circumstance. What about a clinical trial?
The clinical trial. So again, our goal is, like, in what capacity of a clinical trial? What do you mean?
Well, let's say you wanted to prove that your device, to your point, has the outcomes that's safe and effective.
Right.
And you could have a clinical trial. I mean, it happens all the time with drug manufacturers.
So again, when we were doing remote patient monitoring, the whole argument for against reimbursement, even though we had plenty of data, the university said it works. There was like, well, we don't have enough evidence from basically government telling government that this is okay. So they wait on reimbursement policy at the federal level. So again, we want to have a space where the government can say, we saw this, it's going to save lives, it's going to save money, and we need to act on it. And then that can inform the public policy. And that's the goal. The report is just to tell the General Assembly, hey, here's what happened. This can save lives and money, or this is not a good product. This, we're not going to do this. It needs to stay right where it is right now.
I just wonder if a clinical trial can't give you the same information, data.
They can, Mr. Chairman. But what we've seen is even with clinical trials, it's the delay to get it to where it's in the market is a very long time. I mean, we're talking RPM 20 to almost 30 years ago. Yeah. We had clinical trials to prove it. And yet it took the pandemic to get everybody to say, wow, this remote patient monitoring is really going to save lives and money. So we just want to give that ability to expedite that.
Yeah.
And we trust the lawmakers to act on that when they see that information.
Okay, thank you. Delegate Waxman, you have another question?
Yes, I do, Mr. Chair. Thank you. I guess my rub is with healthcare product or service is just so broad. I mean, I can see if someone wants to bring a new drug product to market, that they could use this bill to get that product on the market before it's proven safety and efficacy. And that was the reason that I asked my question. I don't really have a problem with using telehealth, those types of things as a delivery method, but I don't think that we need to be able to introducing unapproved medical devices and medications out there to the general public unless it's through something like a clinical trial. Thank you.
Yeah, thank you, Delegate. I have that same concern about especially things that you ingest or something that goes into your body, device or drug. We might want to have the regulators who have experience doing this to make sure that that's in compliance. Other things like remote monitoring, other things that are innovative AI technology out there, I think that makes some sense, but I'd be concerned about things that are ingestible or injectable or things that go into your body without FDA approval. Delegate Hodges.
Thank you, Mr. Chairman. And I understand your concerns. I don't think it really applies here as far as clinical trials, as far as medications and so forth, because I don't believe the federal government's going to allow that. And I think we do need to have those questions answered. And if it's your goal to really look at the other technologies, and I did some research on this, and where states have made the biggest difference is in telehealth and blockchain technology and other technologies, and it's been phenomenal in other states. And, I'm definitely supportive of the concept because it says Virginia's open for business. We're innovative. We want to bring those businesses, Virginia. We want those startup companies. So I'm wondering if we could possibly get some answers and maybe tweak it a little bit to maybe address those concerns and bring it back next week, because this is something that's very innovative and that is needed in Virginia. But if we could answer those concerns and bring it back next week, so we're all satisfied with that, because I do believe this is something that's very important for the Commonwealth.
My only concern with bringing it back next week is this bill has to go to appropriations, and appropriations deadline is next Wednesday. And this subcommittee, it's on Tuesday. after full, and the full won't meet again until Thursday. So if there's any reworking that needs to be done, it needs to be done today. Unless we schedule another meeting, which I don't know that we are, on Thursday. So let's go ahead and hear some testimony. Maybe that's what we can do. Anyone else wish to seek recognition on this bill? Oh,
Just to
yes, sir.
to emphasize, Americans for Prosperity supports the bill, and we appreciate you. And if there are friendly amendments, we're more than willing to take those to focus on the tech side if that's what works. Any innovation is good, and we need more innovation, especially around blockchain, to make things to share information to make sure that the patient's experience is much quicker and more efficient.
Yeah, okay, good, thank you.
Good morning, Mr. Chairman. Julie Dime on behalf of the Virginia Hospital and Healthcare Association. We appreciate the amendments that the delegate had put forth previously. I think, Delegate Hodges, your suggestions, I think, would be worth considering and very important as well. So we do not have any concerns, but I do think taking Delegate Hodges' concerns into account would be very helpful.
Mr. Chairman?
Yeah, Delegate Hodges.
Thank you, Mr. Chairman. Can we go by temporarily if the patron would be willing to maybe do something by the end of the meeting?
If we could do that. Anyone else seek recognition? Delegate Price.
Yes, thank you. Before you do that, if we are going to go by temporarily, one of the questions that I will be asking, so you might be able to do that, is just if there's no equity within the process on who is chosen to do this. I know that there are not a lot of equitable solutions right now within the tech world. So if that's something that you all could address or be prepared to answer in your sidebar, I would move that this bill go by temporarily.
Is there anything in the bill that would do, how do you choose people that are going to participate? It's up to the company.
Yeah, the Department of Health chooses based on the applicants. Whoever applies has the opportunity to benefit from this.
All right, so maybe something that we could insert in there about equity.
Sure.
Would be helpful in choosing, having that out in the,
but I would,
whenever they put out a request, maybe it's a request for participation or something like that, that's included in there.
And I would be fine if it goes by temporarily.
All right, so without objection, by temporarily. Thank you, Delegate Williams. All right. No. Oh, do we? Okay. All right, Delegate Williams, did you leave?
Yes. We told him to work on the other bill.
Okay, he's going to go work on it. I've been told that there is an exception for us because we're special, so we might get an extra day to work on this. So if we can't, if they go out, I don't want to stop their progress. But if they do come back and able to reach an agreement, then we'll take action. Otherwise, we can do it by. So let's give them a chance to do that. All right, I have Delegate LeVar Bowling here.
She's coming up next.
She's coming up. She's not here. Delegate Anthony, I think, was here first. Delegate Anthony? House Bill 2023.
Thank you, Mr. Chair and members of the committee. Here before you is House Bill 2023. Basically, it's an independent pharmacy support program to establish reporting, and we included a sunset. And so here, we wanted to, provide financial assistance to independent pharmacies in rural and medically underserved areas. And we know like these pharmacies, including independent pharmacists in my district, are often the backbone of healthcare access in communities where large chains have shut down and access to care is limited by geography or transportation network. Here are some highlights of this legislation. It also, again, it supports independent pharmacies that are privately owned and deeply rooted in their community. It will allow them to receive funding and sustain and expand their operations. There is some flexibility use of the funds. The grants can cover essential costs like salaries, inventory, rent, technology upgrades, and training to enhance care. There is targeted oversight. The program ensures accountability with annual reports on how funds improve health care outcomes. And it is tailored for equity. It focuses on pharmacies in both rural and underserved urban neighborhoods to combat healthcare deserts. And so we know that independent pharmacies, are often the lifeline of a community. They provide vaccines, they manage chronic illnesses, they offer the kind of care that you can't get from a chain. And so this bill ensures that pharmacies like this can keep their doors open and continue serving communities. And so with about 210 to 280 independent pharmacies across the Commonwealth, this bill does establish a grant program to fund at least 20 pharmacies across the Commonwealth annually. And so it is a phased-in approach. And again, it does cover staffing, rent, utilities, insurance, technology and supplies, cost of goods. And so I hope it'd be the will of the committee to pass this bill.
All right. Thank you very much. Delegate Anthony, members have questions for the patron? Delegate Hodges.
Thank you, Mr. Chairman. First, thank you for bringing this bill. As an independent pharmacist for 31 years, I know and understand the struggles and what it's like to, and hard to meet payroll and you don't pay yourself. So I greatly appreciate it. This is actually something to help get the independent pharmacies through at least, a short-term stopgap until we can do something long-term. Are you starting to look at and work with the pharmacies, the pharmacy groups, legislators, folks from our side and your side on how we can address that, which would be greatly appreciated?
Yes, I believe
if we could do that, that would be wonderful.
Delegate Anthony.
Mr. Chair, and I believe that there is other legislation to impact long-term sustainability, and this is a short-term piece to provide immediate need.
Thank you.
Thank you, Delegate Hodges. Delegate Waxman.
Thank you, Mr. Chair. If I could ask the patron, what is the criteria for the pharmacy to be able to qualify for this? Is it possibly new opening pharmacies, or are there pharmacies already in existence?
Delegate Anthony.
Thank you, Mr. Chair. I believe that the pharmacies will have to show credentials, of course. And I wanted to make sure that I have this correct within the legislation.
Maybe an earlier version, I was under the assumption it was already existing pharmacies, but I'm not seeing that in the legislation.
It is already existing pharmacies, and there are some independent pharmacies that have expanded their healthcare rather than dispensing medicines. And so it does allow these established pharmacies to expand on that.
Okay, thank you.
Thank you. Delegate, anyone else wish to seek recognition? All right, let's hear testimony from the public. Anyone wish to speak in favor of House Bill 2023? Please come forward. And we're giving 2 minutes per person.
Good morning. My name is Dr. Anna Peoples. I own Peoples Pharmacy located in Norfolk, Virginia. It is an independent pharmacy. First of all, I would like to thank Chairman and the members of the committee for having us here today, and also thank Delegate Anthony for sponsoring this bill. House Bill 2023 will provide financial assistance to help independent pharmacies remain open while we transition over to a health care hub. Currently, a lot of us are actually operating on fumes. So I'm just going to speak from my heart of what we're going through right now. In 2024, four independent pharmacies in Norfolk closed. Across the country, in Virginia, 50 independent pharmacies closed, and they created pharmacy deserts. For most of our population in the communities that we serve, we're the primary health care for those patients. A lot of people walk to our pharmacies. They don't have the ability or the financial resources a lot of them to have transportation to go other places. And so they are very dependent on the services that we provide. If we're not able to get some sort of assistance, then a lot of us will be forced to close down, which will leave a big gap, a tremendous gap in our area. It will become a pharmacy desert. So what we're asking for is resources to help us transition over to a healthcare hub. So what is a healthcare hub? A healthcare hub is a place where right now a lot of us are transitioning over as much as possible. At People's Pharmacy, our healthcare hub is you can come in, it's almost like a one-stop shop where you can have telehealth services with your physician as well, get your medications. We have labs there, and so it would be comprehensive health care for people, and especially with the physician shortages that we're seeing in Virginia, especially in our area. We just had a roundtable about that. These pharmacies are critical to the communities that they serve. People come to us first, a lot of times before they go to the hospitals even, because they know what they're going to experience once they go there. We are one of the most accessible healthcare providers overall. It's not too many providers that you can go in and speak to someone about your health. If you have a cough, you have a cold, you can always go to your local pharmacist, and we have a consultation room. Can you help me out with this?
Okay.
And so this is critical.
Thank you very much for your testimony. Appreciate it very much. Anyone else here to speak in favor?
Thank you.
Thank you. Welcome.
Hello. Hi, my name is Kim Wright, and I'd like to thank the chairman and the committee and Delegate Anthony for bringing this bill forward. I'm a pharmacy owner and a pharmacist in Cumberland County. In Cumberland, we are the only access point for healthcare. There's no medical provider other than us. So, you know, our patients come to us for everything. We are basically month to month at this point due to lack of reimbursement for prescription medications. And, you know, if our pharmacy was gone, that would impact our community. It would be devastating. You know, we also, just like Dr. Peoples, are trying to establish ourselves as a healthcare hub with a point of service for telehealth, as most folks out there don't have internet access or even smartphones, so they can come to us, you know, in order to receive care. Since now we have provider status, we can do point of care testing and even prescribe. However, our problem is we don't have the funds to be able to have the appropriate equipment that we need, technology, and staff. So I really appreciate the committee's time, and you know, and thank you again.
Thank you. Anyone else here to speak in favor of House Bill 2023? Step on up.
Hey, my name is Jeremy Counts, Counts Family Pharmacy, Pharmacists United for Truth and Transparency. First, thank you all for having me. Thank you for introducing this bill. First and foremost, I want everyone to know this is a patient access issue. As they touched on before, patients have a hard time getting into primary care physicians. It is expensive a lot of times to go to an emergency department, to go over to critical care. It's tough to do that. Pharmacies are a way for them to go, to have access, to get access to the entire healthcare system. But we're being decimated. Under reimbursement has our hands completely tied. We can't expand. We can't offer more services because we don't have the money to do so. This bill would allow us to try and put these services in our community so that these patients can access them. And I encourage all of you to please support this bill. You know, it's not only just supporting pharmacies so that we stay open, so that in case another pandemic happens or something else, we're there again on the front lines like we were asked to be. Not only do that, but for the patients, give them access to this healthcare system. It's worth the time.
Thank you.
Thank you
very much. Anyone else here speak in favor? Don't be shy. Come on up. Like walking down an aisle.
I'll be brief. Members of the committee, Mr. Chair, my two esteemed pharmacy colleagues, thank you for allowing me to speak in favor of this bill. My name is John Beckner. I'm with the National Community Pharmacists Association. We represent the nation's independent community pharmacies, of which Ms. Wright and Ms. Peoples are members. We recently did a study regarding pharmacy deserts, which are cropping up all over the country. Our studies have shown that roughly, on average, one independent pharmacy a day has closed over the last 2 years, creating these pharmacy deserts. Obviously, from a business standpoint, we're concerned that our members are closing, but even more important are the downstream effects on access to health care. When you think back on the COVID-19 pandemic, the pandemic shone a very bright light on what pharmacists are capable of doing, particularly in the immunization space. And certainly if pharmacies continue to close and we have other healthcare crises, that creates a problem. So we really appreciate your consideration of this bill. Thank you.
Thank you. Thank you. Anyone else here to speak in favor? Anyone to speak in opposition to this really good bill? All right, hearing none. Is there anyone else wish to speak recognition? I think Delegate Willett.
Thank you, Mr. Chair. First, just share a couple of comments, and then I do have a motion at the appropriate time. First and foremost, thank you, Delegate Anthony, for bringing this bill forward. Wearing a couple of hats here, including having chaired the Rural Health SLIQ Committee, where we toured Virginia and heard time and time again about the issue of access to pharmacies. It is a statewide issue. The rural areas, urban areas, we were focused on the rural side of that, but we did hear it time and time again. And to Dr. Peebles' excellent point, we also heard how critical these pharmacies are in providing basic health care. They really are, for a lot of people, the only health care access that they have. So this is a critical issue. What I wanted to mention for the committee's benefit, for the patrons' benefit, is wearing another hat with the Joint Commission on Healthcare. We did vote at our last meeting to include studying the pharmacy access issue in our 2025 work plan, excuse me. And this is absolutely front and center to our work. Delegate Waxman is part of that and sort of led the charge to add that to the study. So my suggestion, I guess would be my motion, is that we send this bill to the Joint Commission and include that as part of the study where we look at the broader pharmacy access issue.
Okay, so hold on to that. Delegate Waxman, you wanted to seek recognition also?
Yes, if I could, Mr. Chair, I'd just like speaking to the bill. I would encourage our members to please support this. I've been there. As many know, I was forced to sell my pharmacy in 2019 due to low reimbursement rates. At the time, I was trying to implement some clinical skills. My pharmacy, the next nearest one, was 20 miles away. It would have been a really valuable area. And I really appreciate the delegate for bringing this bill. It's much needed when I wanted to expand into more clinical areas. Because of the reimbursement side, my resources had been depleted, so I could not move forward to serve my area. So I'd just like to speak in favor of this bill.
Thank you, Delegate Waxman. Delegate Hodges, you're also recognized.
Thank you, Mr. Chairman. And again, thank you for bringing this legislated. It is needed, and it's needed now, because pharmacies are closing, as Mr. Beckner said, at least one each day. And as they close, the problem only grows. And I appreciate Delegate Willett and your concerns, but sending to the Joint Commission, I think that would be a year's delay. And we need to get this going now, and to be able to start the fund as we work forward and move forward with the Joint Commission, and as we all work together to start to solve these reimbursement issues and start to really look at the problems that are affecting these pharmacies. And some of the pharmacies that I've actually visited, as many as, especially the high Medicaid stores, as many as 30 to 40% of the prescriptions are reimbursed below the cost. Now, I'm not talking about the cost to dispense and the drug. I'm talking about the cost below the drug itself. You can't even pay for your bottle and your label, plus your rent, plus your lights, plus everything that it takes to run the business. And it takes a long time to make that up. And especially when if you have a $1,000 prescription and you get paid $800, make that $200 up on a 37-cent reimbursement. It takes a long time. So this is something we need to really move forward with now, to be able to put that into place. And as we all start to move forward, we can start to work with the Joint Commission. We can start to look at reimbursement. And there are other pieces of legislation that are moving forward. And we all need to work together in those pieces of legislation to solve this problem. And thank you.
Mr. Chair, is a parliamentary inquiry, is there a motion on the table already?
I didn't get a second.
Oh, second.
Second. With a motion, do we want to restate your motion, Delegate Willett? So I guess it would be to lay the bill on the table and to maybe send a letter to the Joint Commission on Healthcare, have the Uber chair send a letter to ask them to include this item in their
Mr. Chair.
study. Yes.
Before you carry out that motion, I would like to note that there is a reporting infrastructure already built into this bill that will already go to the Joint Commission. So I'm not sure of the delay, but this bill is absolutely needed at this moment.
There is, it has to go to appropriations. I got that message.
Mr. Chair, if there's a...
Delegate Herring.
Thank you. Is there, on the FIS, does it have an amount that...
We have not seen a FIS. We
must have a letter.
anticipated, for, on the caboose year, at least the first year to get started at 1.3 million.
Yeah. Yeah, there must be, if there's going to receive funds for the program, there must be some fiscal impact to this. So I restated the motion, but I don't know if I got a second or anything like that for my motion that I restated that I thought Delegate Willett said.
I was going to say what you said on the motion.
All
Let me
right,
get a second on that.
so that's the motion. It would be to lay the bill on the table, to have a letter sent from the chair of HHS to the Joint Commission on Healthcare that they include this aspect. All right, so that's to restate that motion, and I think someone did second that. All right, subcommittee will vote to lay on the table. Some of you might want to call roll. Okay, we're going to call roll.
Okay. Delegate Price.
Aye.
Delegate Willett.
Aye.
Delegate Herring.
Aye.
Delegate Shen. Aye. Delegate Hodges.
Nay.
Delegate Taylor.
Nay.
Delegate Waxman.
Nay.
Chairman Hope.
Aye. All right.
5 to 3.
5 to 3, the bill, the motion to lay on the table passes.
Thank you, Mr.
Thank
Chair.
you, Delegate Anthony. Appreciate it. This is good work. Will to be continued, and we look forward to working with you in the Joint Commission on Healthcare. All right, Delegate Loeffler, I think I have you next. And Delegate LaVere Bowling, you're going to be in the queue, if that's okay.
Yep. Thank
right.
you.
House Bill 1976 is before us. And this bill also, if it's favorable, has to go to appropriations.
I'm sorry, I cannot hear you. So,
This bill also has to go to the Appropriations Committee if it's favorable. So I just wanted to make sure everyone's aware. House Bill 1976.
all right. Good morning, Mr. Chairman and committee members. House Bill 1976 directs the Department of Health to implement a pilot program that provides for remote patient monitoring for maternal hypertension and maternal diabetes for 300 eligible participants. Maternal outcomes are worsening. Hypertension and diabetes are leading causes of maternal and infant morbidity and mortality. In 2023, maternal mortality, preterm birth, and infant mortality worsened in Virginia.
Between 2015 and 2022, pre-existing hypertension rose 80% and pre-existing diabetes by 50%. These conditions increase the risk of infant mortality, C-sections, postpartum hospital readmissions, birth defects, and preterm births. The bill requires the department to select a managed care organization and technology vendor to administer the pilot program. The bill requires the department to submit a report to the governor and General Assembly no later than 18 months after the first eligible participant is enrolled in the pilot program. Similar programs have been implemented in Georgia and Florida to great success. Maternal morbidity dropped 50% in Florida. Initial testing of 2,500 pregnant people and emergency room visits dropped as well. HB 1976 leverages technology to improve maternal health outcomes during pregnancy and up to 3 months of postpartum, fostering collaboration between healthcare providers, managed care organizations, and technology vendors to streamline care. This would improve accessibility to healthcare, especially for vulnerable populations, while creating cost-effective healthcare innovations that reduce emergency interventions and improve healthcare access. Access to maternity care is getting worse. As more moms have higher risk pregnancies, access to care is worsening. For example, 30%, a little over 30% of Virginia counties are maternity care deserts, with no obstetric hospitals or birth centers and no obstetric providers. Remote patient monitoring improves outcomes, access to care, adherence, and health care costs. And I hope it's the will of the board to pass this.
Thank you, Delegate Loeffler. Any members wish to ask a question of the patron? Mr. Uber Chair.
Thank you. I just wanted to ask.
Dr. Sickles.
Thank you. Sickles, MD. I wanted to ask about what we're doing in Medicaid with regard to telehealth policy and this same subject within Medicaid instead of the health department. Is there somebody that might know the answer to that, counsel, or someone from DMAS in the audience that could, because this is you're going to start a new program in the health department.
Well, actually, it's a managed care organization, which could be Medicaid.
No, that
or
would be
will
Medicaid.
be.
That would be Medicaid.
Yeah.
Okay. So, but what I'm reading, I guess, is a short version. It says Direction Department of Health to implement a program. Well, maybe you can tell us how these two programs will work together in the Department of Health and DMAS. Or
I definitely would.
I don't see anyone jumping up from DMAS. There's got to be someone hiding in here.
Okay. Mr. Frank is going to come up and
thank you.
Help us out. Mr. Frank, thank you. Welcome. It's good to see you.
Mr. Chair, Will Frank with DMAS. So it's my understanding with this bill, there's a few remote patient monitoring bills out there this session, some with DMAS. This one is with VDH. We already do remote patient monitoring for pregnant women at risk, is already implemented at DMAS. We already do cover some telehealth. So this, I think you would have to look at this maybe in the context of some of the other legislation that is around remote patient monitoring this session. That's coming to this committee or already has come to this committee.
Okay, Mr. Chairman.
Mr. Chairman, Chairman Sickles.
Is there a fifth on this bill? I mean, I think it's a little slow.
Yeah, Mr. Chairman, we were told it has to go upstairs if it's.
Yeah, but I would just.
Favorably.
There is 600,000.
That's right. You'll see it up there. All right. Anyone else wish to seek recognition? Anyone here to speak in favor of House Bill 1976? Please line up. 2 minutes apiece. You can be shorter. There's a long line here.
Hi, my name is Jennifer Hubert. On behalf of the Virginia Society for Human Life, we are strongly in favor of this bill and we support passage and urge passage.
Thank you so much.
Mr. Chairman, Dylan Bishop on behalf of Motive Care Solutions. Motive Care provides a non-emergency medical transportation brokerage for Virginia's fee-for-service population. We also provide remote patient monitoring services specializing in maternal health data. So we support this legislation. Thank you.
Thank you.
Good morning, Mr. Chairman, members of the committee. Amy Perrin-Seibert on behalf of Baby Scripts. We're a company that's been around for 10 years who does remote patient monitoring for pregnancy, and we do this on apps already. And so we are very excited about this bill and think we can expand our efforts here in Virginia to be able to do this program. So appreciate the opportunity for that. Thank you.
Mr. Chairman, members of the subcommittee, Nicole Lauder on behalf of the American College of Obstetricians and Gynecologists. I want to thank the patron for the bill. I think this is just another tool in the toolbox to help us ensure that women are being screened and get the treatment they need early on in their pregnancies. So thank you.
Very
we
good.
support the bill. Sorry.
Thank you. Hi, welcome.
Hi, good morning. Mr. Chair, members of the committee, my name is Latoya Mathias from Progress, Virginia. I'm also here on behalf of our partners at Birth and Color. We both support the bill. Thank you.
Very good. Thank you.
Good morning again, Mr. Chairman. Julie Dime on behalf of the Virginia Hospital and Healthcare Association. Associate my remarks with those before me. We support the bill.
Thank you. Anyone here to speak in opposition? We do have one or two people online. I'll get to you in a second. Anyone here to speak in opposition to the bill? All right, so let's go to online. Mr. Hoffman, you have 2 minutes. Mr. Hoffman, thank you.
Hi, Chairman Hope. My name is Evan Hoffman. I'm a Director of State Government Affairs with Philips, another healthcare technology provider. It sounds like there's a couple others in the room. We also have been offering remote patient monitoring services for pregnant individuals with high-risk complications. I'm not going to dive into a lot of what was already spoken, but we definitely support this bill, and we support a pilot program because it's a very targeted policy response that will have an immediate impact on pregnant people who have those complicated pregnancies and are at highest risk for complications. And so following the lead of Georgia and Florida, I think this is a great opportunity for Virginia to implement a specific policy response that has proven dividends and improved outcomes elsewhere. So thank you.
Thank you, Mr. Hoffman. Anyone else here to speak in favor or opposition to the bill? All right, delegates, Chairman Sickles, you recognize is that an old request or new one?
Could you repeat the question, Mr.
You have a
Chairman?
request to speak. I see a little button here that says Sickles.
No, I
Okay,
forgot
that's
to
an old
turn
one.
that off. But
all right. So anyone else to have any questions for the patron? We work by motion.
Mr. Speaker. Mr. Chair, I was going to ask to speak to the bill and have a motion.
All right.
Thank you. Just wanted to say thank you to the patron. Thank you
patron, all
to the
same.
patron for focusing on patients. And I know that this also goes to some of the disparities that we've discussed within the Black Maternal Health Summit, where I know you were also there and participated. So with that, Mr. Chair, I would move that we report House Bill 1976 and refer to appropriations.
All right, got a motion properly second. Members, please cast your vote on the electronic voting board. Oh, we're not up yet. Clerk will call the roll.
Okay, Delegate Price.
Aye.
Delegate Willett. Aye. Delegate Herring. Aye. Delegate Shen. Aye. Delegate Hodges.
Aye.
Delegate Taylor. Aye. Delegate Waxman.
Aye.
Chairman Hope.
Aye. Bill passed 8-0. Motion to refer and report to appropriations.
Thank you. And I just want to say about this bill, this is very personal. My mother was a high-risk pregnancy with her eighth child, gestational diabetes, hypertension, rushed to the hospital, all the things that we're talking about. Obviously, this was a long time ago, but I know this bill will save lives. Thank you very much.
Thank you for bringing it, Delegate. All right, Delegate LaVere Bowling, House Bill 1918. Thank you for your patience.
Thank you, Mr. Chair.
And I'll make everyone else aware that we got a letter on this bill as well, too.
Okay, perfect. So good morning to all of you. Thank you for your time. I do have a substitute for this bill, and I would kindly ask that you all move the substitute.
All right, the clerk will report to substitute.
Mr. Chair, the substitute strikes, if you're looking at the bill, subdivision C1 and also subsection D, but these both are dealing with treatment provisions in the bill. This is changing the bill to be focused more on education instead of providing actual treatment and screenings. Pardon me. That should be all.
All right, that's the substitute. Can I get a motion to approve the substitute? A motion properly second. All in favor say aye. Aye opposed. All right, substitutes before us.
Thank you. So this piece of legislation establishes the Women's Menstrual Health Program, which is a critical step forward in addressing menstrual health and the associated conditions that impact countless Virginians. This bill creates the Women's Menstrual Health Program to identify and assist individuals experiencing symptoms of menstrual disorders, including endometriosis and polycystic ovarian syndrome, also known as PCOS. These conditions are typically underdiagnosed, and they often lead to years of pain, untreated symptoms, and a diminished quality of life. By leveraging evidence-based guidelines from respected organizations such as the American College of Obstetricians and Gynecologists, this program ensures a robust and compassionate approach to menstrual health care. Within the bill, you'll see that the Department of Health will provide training and educational resources for healthcare providers, emergency hospital staff, and the public about menstrual health, the screening, and the care. These resources will be based on evidence-based clinical guidelines, promoting early identification and detection, along with appropriate treatment of such menstrual disorders. I also in the bill have put that the department's website will host those educational materials, and the program will enhance awareness and early detection of those menstrual disorders. We all can agree that menstrual health is a vital yet often overlooked aspect of public health, and by implementing this program, Virginia can lead the way on providing comprehensive support for individuals affected by menstrual disorders. So I would ask kindly and urging the committee to support this bill and help improve the lives of thousands across the Commonwealth.
Thank you, Delegate.
Thank you.
Any members have a question? Yep. Delegate Hodges.
Thank you, Mr. Chairman. In looking at this, I would assume since we're directing the commission to do all of this, there would be a fiscal impact, but I'm looking at your budget amendments. Did you put in a budget amendment for this actual bill?
Yes. So the answer is short, Mr. Chair. The answer, I would answer the delegate that yes. We do have one in, but we also are awaiting a new fiscal impact based on the substitute.
Okay. And with this, we do have a letter, as I mentioned earlier, so if this bill is acted favorably, it will have to go upstairs. All right, any other questions from the members? All right, anyone here to speak in favor of House Bill 1918? Yes, please come forward.
Mr. Chairman, members of the subcommittee, Nicole Lauder again on behalf of the American College of Obstetricians and Gynecologists. I want to thank the patron for her introducing the bill and look forward to working with her and the Department of Health to make sure that the materials that we have already on this subject matter can be used. We screen patients for this every day and see it every day and know it's a vital resource to be able to help them ensure that they get the treatment that they need. So thank you.
Thank you.
Hello, Mr. Chair, members of the committee. LaTwyla Mathias again from Progress, Virginia. On behalf of ourselves and Birth and Color, we support the bill and we thank the patron for bringing it.
Thank you very much. Anyone want to speak in opposition to House Bill 1918? Delegate Price, you are recognized.
Yes, thank you, Mr. Chair, and to the patron, just wanted to say thank you. It is so wonderful to have a partner in good trouble for this. When we did the resolution to establish PCOS Awareness Month, it wasn't until then that when I'm walking around the grocery store and people are coming up to me, there are so many women that are late diagnosed and could have been saved years and years of pain and agony if only they had known sooner and gotten more information. So with that, Mr. Chairman, I would move that we report with substitute and refer to appropriations, House Bill 1918.
All right, got a motion. Properly second. Any questions for the patron or on the motion? All right, hearing none, please vote on your electronic voting device. It works. All members cast their votes. All right, bill reports and refer to substitute to appropriations on a vote of 8-0. Thank you so much, Delegate.
Thank you so much.
All right, last two bills as we have, yes, Delegate Price.
Yes, I'm sorry. Before we forgot, I did want to make a motion. I move that we would take House Bill 1555 by for the day now that we know that we don't have that same deadline. And I did speak with the patron and he was thankful and agreeable to that motion.
Thank you for doing that. I've got a motion. Can I get a second? All right, motion goes by for the day. All right, Delegate Willett, you and I are next, and so the only patrons that are here, and so I'm going to turn to you first. Okay. House Bill 1905.
Great, thank you, Mr. Chair. I first want to move a substitute.
All right, we've got to get the clerk to report to substitute.
Mr. Chair, the substitute replaces the stricken language in lines 28 and 29, so that is reinstated. Additionally, it specifies that distribution is allowed in health systems under common ownership, and I think that should be the only change in terms of, everything is still administered to patients only within the hospital or health system, but it specifies that it's health systems under common ownership.
Okay, I got a motion to approve the substitute. Can I get a second? Second. All in favor, say aye. Aye. Opposed? Okay, substitute is before us. Delegate Willett, tell us what your bill does.
Thank you, Mr. Chair. This bill will remove the current prohibition for hospitals from compounding needed medications and then distributing them to other hospitals within the same health system. This is going to support hospitals being able to provide timely access to needed medications and the flexibility, particularly during emergencies and drug shortages in the Commonwealth. Centralized compounding allows faster responses to patient needs while utilizing outsourcing pharmacies to help fulfill their routine needs. Mr. Chair, I welcome questions from the committee.
Okay. Any questions for committee members about House Bill 1905? All right. Seeing no one seeks recognition, is there anyone here to speak in favor of 1905? Please come forward, identify yourselves, and tell us why you like the bill.
Good morning. My name is Natalie Nguyen from the Virginia Society of Health System Pharmacists. Thank you, Patron Willett, for supporting this bill. I'm here again to talk about how this bill removes that prohibition for hospitals for us to compound needed medications and to distribute them to other hospitals, again, within the same health system. This specific prohibition only exists in the Commonwealth and not in other states. An example of how this was critical was during the Hurricane Helene disaster, where IV fluids were on shortage. Hospitals that ordered a drug called oxytocin, a drug used for preventing fatal, uncontrolled postpartum bleeding, were also unavailable to order this drug from external 503B pharmacies, also due to the shortage. Being able to compound and distribute this within house facilities where appropriate would help us sustain the critical care in the role of preventing maternal deaths. Please do not let the failure of this bill be a reason why we are unable to care for our patients. Passing HB 1905 will allow us to provide the continuous care regardless of any of these external factors. Thank you.
Thank you. Hi, welcome.
Good morning, Mr. Chair and delegates. On behalf of VCU Health was able to greatly benefit through the governor's waiver exemption during the fluid shortage crisis in the fall of last year, and also hospital-specific exemption during the recent January water interruption crisis. With this, we were able to quickly pivot and provide continuous critical care to all of our patients when buildings were closed due to lack of heat, lack of water, steam, and we were able to centralize compounding operations with centralized resources to provide sanitary conditions. Support on House Bill 1905 to help institutions like VCU Health continue to operate as a level 1 trauma center during and not during times of crises. Thank you.
Thank you.
Mr. Chair, members of the subcommittee, Brent Rawlings, Virginia Hospital and Healthcare Association. We strongly support the legislation. Everything you've heard before is exactly right on. We, in this Baxter Helene example, struggling working with the state health commissioner to find a way under the executive order. State of emergency ends and we still have this supply chain resiliency issue. And so this is just another example of what we learned through periods of crisis that we can put in place and codify going forward so that we don't face the same challenges going forward, and hope you support the measure.
Thank you, Mr. Rawlings. Before I turn to online, is there anyone here to speak in opposition in the room? All right, so let's go ahead and go online. And we have Dr. Joshua Crawford here to speak in favor of 1905. Dr. Crawford, welcome.
Yeah, hey, good morning. My name is Josh Crawford. I'm a Virginia-based hospital pharmacist with 14 years experience, and I'm here to speak on support of this bill. In my career, I've seen many instances where giving hospitals the ability to support each other within the same health system would prove beneficial to patient care, which is what this bill intends to do. I'd like to share just a few quick examples that I've witnessed relatively recently. Of course, we've all been impacted by the Richmond City water outage, and that caused severe disruptions in pharmacy operations at 3 hospitals within my own health system and 5 within my community. We've also experienced neurovirus outbreaks, which unpredictably impact departments. Leads to staffing shortages when respecting established quarantine periods. It would have been immensely helpful if hospitals just a few miles away within the same health system could have jumped in and helped make sterile compounded products ahead of time to reduce workload at the impacted hospital and reduce delays in delivering patient care. And obviously, we've already touched on medication shortages, and no hospitals are immune to that in the last decade plus. And finally, another issue that we've encountered are actually clean room air handler malfunctions, which is not something you may think of, but just to give you a little background, clean rooms are $1 million rooms in our hospital pharmacies in which we compound sterile injectable medications. And unfortunately, these are not immune from HVAC issues, just like our houses. And we've actually had air handlers break or not function when they're brand new at multiple Virginia hospitals over the past few years. And this took 2 to 3 months to rectify, during which time those hospitals could not make medications ahead of time for our usual workflow. The changes in this bill would allow other hospitals within our health system to fully functioning clean rooms to help prepare products while the repairs were underway. And one thing to keep in mind is that all hospitals within the Commonwealth of Virginia operate under the same laws and regulations. So a sterile compounded product made at one hospital in preparation of patient care should be equally as safe as one made at another hospital under the same health system. So thank you guys thank you all for hearing us today and considering this legislation.
Thank you very much. Any other member wish to seek recognition or have a question of the patron? Otherwise, I'll give you the final word, Delegate Willett.
Mr. Chair, I just appreciate the committee's time. I think this is an important bill. It's going to help a lot of pharmacies deal with the issues you've heard.
Okay. All right.
Today.
What's the pleasure of the subcommittee? All right, got a motion to report properly second. Please vote on your electronic voting device. Oh, with the substitute. Excuse me.
Substitute.
All right, well, we're going to have to open up the roll. Oh, there we go. Delegate Willett, I'm assuming going to vote aye. Okay, so bill reports with substitute on a vote of 8-0. All right, the final bill is, which is why everyone's still here, is the House Bill 1637, which is mine. If I can turn it over to Chair Price.
Sure.
I'm going to stay right here if that's okay.
Yes,
Is that all right?
allow it this one time.
Thank you.
Mr. Chair, please proceed.
Thank you very much. This bill is a very simple bill, famous last words. It's just going to add, it's more of a technical change than anything else. It permits persons that are already acting on behalf of an organization that provides services to individuals at risk of experiencing opioid overdose or training in the administration of naloxone or other opioid antagonists. We're just adding those words, or other opioid antagonists, to the part of the code. And if you look at the language that's before you, lines, well, it starts on line 303, wherever you have the word naloxone, it adds the words or other opioid antagonists. When we wrote this statute originally, naloxone was the only drug out there, but there are others that have come online. And we just wanted to allow those other uses for the individuals that are already permitted to do the prescribing, to allow them to use other opioid antagonists as well. And so it's more of a technical change than anything else, but a necessary one. And so that's the bill that's before you. It's very simple.
Thank you, Mr. Chair. Are there any committee members that have any questions? Is there anyone here to support the bill? Oh, I'm sorry. Delegate Waxman.
Thank you, Madam Chair. Was just, in listening to the purpose of the bill, is there any reason that those prescribers can't already prescribe those the opioids that we need this legislation?
We might have a phone a friend here. I mean, just the statute is so pure about the restrictive to just naloxone. It would not permit other things. But
yes,
Nicole?
sir. Yes, Mr. Chairman, members of the subcommittee, Nicole Lauder, here on behalf of Indivior, which is one of the companies, many companies that make this other opioid antagonist product. There's a few, but yes, our folks were experiencing some trouble in that when an individual or an organization would ask for their particular product to be prescribed or to be available, we're told this code just says naloxone or Narcan right now, so we couldn't do any. They assumed that they would not be able to obtain the product, our product.
Okay, Madam Chair, if I could ask a follow-up?
Sure, Delegate Waxman.
Okay, so naloxone right now is across the counter, doesn't require a prescription.
It does not, no, sir, you're right. So that change has been made since.
Are these organizations not licensed, or do they not have licensed people?
The particular example that we were given were community service boards that were experiencing, they were just reading the code, and because they were, it says particularly naloxone right now, they were apprehensive to prescribe other opioid antagonist products.
Madam Chair, if I could ask a follow-up?
Yes, Delegate Waxman.
So the naloxone is available without a prescription, but wouldn't the others require a prescription?
They do require prescription, yes, sir.
Okay, thank you.
Yeah. So it would, Mr. Chair,
Yep.
I'm sorry. It wouldn't restrict, Mr. I'm sorry. It would not restrict, it is just permissive to allow them to be able to use other products other than naloxone. So to your point, sir.
Okay. Yeah. Is there anyone else here to speak? Oh, I guess, let me start. Is there anyone here to speak on in support of the bill? Is there anyone here to speak in opposition to the bill? Do we have anyone online? Okay. Delegate Hope, did you want to have the final word?
No, I appreciate it. Again, this is just a technical change where we're putting this in to allow other opioid antagonists, since there's already, naloxone's already in the code, it's very prescriptive. We want to allow for others that have come on the market to be available and accessible.
Delegate Willett?
Second.
It's been moved and properly seconded that we report House Bill 1637. If the clerk will please open the roll. And that bill does report 2 full on a vote of 7-1, turning it back over to you.
All right. Thank you very much, Chair. Thank you to Subcommittee. We stand adjourned.